What is the yield of MRI for sudden sensorineural hearing loss? I'm Francis Deng, neuroradiologist at Johns Hopkins. In this AJNR article summary podcast episode, we feature an article selected for the Fellows Journal Club entitled Retrospective Review of MR Findings in Sudden Sensorineural Hearing Loss and Associated Clinical Features. The first author is McKinnon Brennan, and the senior author is Katherine Reinshagen, assistant professor at Harvard and Mass Eye and Ear. First, by way of background, sudden sensorineural hearing loss is a dramatic and often alarming clinical presentation. Patients will present to the clinician complaining of sudden hearing loss, usually in one ear, occasionally in both. And the clinicians have to distinguish between sensorineural hearing loss and conductive hearing loss by using a tuning fork and audiometry if available. The annual incidence of sudden sensorineural hearing loss is about 27 per 100,000. Sudden sensorineural hearing loss is defined as the new onset sensorineural hearing loss from onset to peak symptoms within 72 hours of at least 30 decibels across 3 contiguous frequencies tested by audiometry. Because premorbid audiometry is frequently not available for comparison, hearing loss is functionally defined in relation to the opposite ear's thresholds. The condition commonly presents alongside symptoms like tinnitus and vertigo, and often leads to urgent clinic or emergency department visits. The American Academy of Otolaryngology Head and Neck Surgery Clinical Practice Guidelines, or CPGs, recommend 2 things with respect to the imaging of sudden sensorineural hearing loss. First, clinicians should not order routine CT of the head in the initial evaluation of a person with presumptive sudden sensorineural hearing loss. Second, clinicians should evaluate patients with sudden sensorineural hearing loss for retrocochlear pathology, and MRI is the most sensitive means for diagnosing retrocochlear pathology. This was a large retrospective study of patients diagnosed with sudden sensorineural hearing loss and no trauma, surgery, or previously known temporal bone pathology, who presented to Mass Eye and Ear between 2015 and 2022. There were 841 patients included, so that's about 10 patients a month presenting for MRI for sudden sensorineural hearing loss at this one center. That's a relatively high volume. Mass Eye and Ear has 9 neurotologists and many more affiliated general ENTs, so this large number makes a lot of sense to me, having trained there. About 10% of patients had bilateral symptoms, so individual ears were counted as the denominator in subsequent analyses, so that's 929 ears. And of these, negative MRIs without retrocochlear pathology was the vast majority at 94.1%. So the positive yield was 5.9%. So let's take a look at the figures to see the spectrum of relevant pathology that we should be on the lookout for. Vestibular schwannomas accounted for 1.5% of the ears. Figure 1 shows a 43-year-old patient with sudden right hearing loss. And on high-resolution T2 drive images, there's a mass in the right internal auditory canal and cerebellopontine angle cistern, which on thin T1 post-contrast images shows homogeneous enhancement and no dural tail, consistent with a vestibular schwannoma. Cochlear schwannomas accounted for 0.9% of symptomatic ears. Figure 2 shows a 63-year-old patient with sudden left hearing loss. The T2 drive images show a filling defect, kind of a loss of fluid signal, in the scala tympani of the basal turn of the left cochlea, which on T1 weighted images showed mild intrinsic T1 hyperintensity, but there was obvious post-contrast enhancement. At this stage, this could be hemorrhagic labyrinthitis or a schwannoma, but on follow-up MRIs extended out for at least 2 years here, shows persistence of those same findings, indicating that this is an intralabyrinthine or cochlear schwannoma. Meningiomas accounted for 0.3% of symptomatic ears. Figure 3 showed a 47-year-old with sudden left hearing loss and tinnitus. The T2 drive image showed a mass in the left cerebellopontine angle cistern, compressing the pons and not extending into the internal auditory canal. Post-contrast imaging showed avid contrast enhancement and a dural tail, consistent with a meningioma. Labyrinthitis accounted for 2.3% of symptomatic ears. Figure 4 shows an example. 91-year-old presented with sudden right hearing loss. Pre-contrast T1 showed intrinsic T1 hyperintensity in the vestibule, and post-contrast T1 showed contrast enhancement in the vestibule as well as within the posterior semicircular canal. T2 drive images shows mildly diminished fluid signal in these areas, suggestive of hemorrhagic labyrinthitis. Congenital anomalies accounted for 1% of the symptomatic ears. Although these are congenital, in theory, they do not always present with hearing loss at birth. Patients may present with sudden hearing loss, predisposed by this anomalous anatomy later in life. Such cases in this cohort included a case of cochlear nerve hypoplasia, several cases of enlarged endolymphatic ducts, as well as the combination of enlarged endolymphatic duct and incomplete partition type 2, historically known as the Mondini anomaly or Mondini malformation. If you're not familiar with how to recognize these latter conditions on MRI, as they're more commonly diagnosed on temporal bone CT, I would refer you to Katherine Reinshagen's earlier AJNR article published in 2017, Measurement for Detection of Incomplete Partition Type 2 Anomalies on MR Imaging. So if you take a heavily T2 weighted image at Mass Pioneer, they do T2 drive on Philips scanners. You can see the endolymphatic duct that is abnormal. Here it's labeled EVA in reference to what we would call it on CT. The EVA is the enlarged vestibular aqueduct. That's the bony structure that contains the enlarged endolymphatic duct. And so if we see fluid signal there on MRI, we call that an enlarged endolymphatic duct. So that's part of the membranous labyrinth that contains fluid and it's lined by epithelium. So on MR, since we see that fluid signal, this is abnormally enlarged endolymphatic duct. And then moving on to recognize cochlear incomplete partition type 2, you have to have image quality that is good enough to resolve the osseous spiral lamina and basement membrane complex. This is the bar that kind of separates the scala tympani from the scala vestibuli and media. So on axial images, you want to measure from this line that represents the osseous spiral lamina and basement membrane complex and go to the next line anteriorly. In normal cases, that next line would be the interscalar septum, but in IP2, the interscalar septum is absent. So the next line you would encounter is a dysplastic band that represents the osseous spiral lamina basement membrane complex for the upper turns of the cochlea. When that distance between these two lines are less than 1.2 millimeters, that's normal. And when it's greater than 1.2 millimeters, that is indicative of incomplete partition type 2. Incidental actionable findings were found in 1.4% of patients. These included aneurysms, a low-grade glioma in one case, and actually most commonly a contralateral vestibular schwannoma. In figure 5, a 55-year-old patient had sudden right hearing loss, but also had a long-standing history of left ear hearing loss. The T2 drive images disclosed a mass in the left pars acousticus and cerebellar pontine angle cistern, which enhances on T1 post-contrast imaging without a dural tail, consistent with a vestibular schwannoma, which explains their long-standing asymmetric hearing loss on the left and not the sudden hearing loss on the right. I should note that if they had presented earlier to an otolaryngology clinician with asymmetric hearing loss, and this was found to be sensorineural, they likely would have had an MRI to work that up, as that is a separate indication for MRI evaluation of retrocochlear pathology. In this study, we're dealing with sudden sensorineural hearing loss, however. The authors concluded overall that the incidence of relevant retrocochlear tumors on MRI performed for sudden sensorineural hearing loss is less than 3%. About 2% of the patients had MR evidence of labyrinthitis, but the clinical relevance of this finding is muted, as most patients presenting with sudden sensorineural hearing loss are going to get steroids anyway, which is also the treatment for labyrinthitis. In my opinion, it is also important to consider, however, the possibility that enhancement in the cochlea at the initial time point could either be labyrinthitis or an intracochlear schwannoma, and the need for follow-up imaging should be considered, guided by whether there is improvement in their hearing after the initial episode. These authors make one final point that is relevant to imaging protocols. They point out that all the tumors that they had in this study were detectable on the non-contrast heavily T2-weighted sequence alone. So they suggest perhaps you could adopt a limited MR protocol that takes only 10 minutes, consisting of a non-contrast, heavily T2-weighted image, maybe you would add in a DWI or flare to evaluate for acute ischemic stroke or demyelinating disease, but they did not have any such cases in their cohort here. And this would improve resource utilization. So that's food for thought. I don't know of any practices adopting that at this point, but thanks for listening to this AJNR article summary. I'm Francis Deng. I'll see you next time.